Our next speaker is one of my favorite MS doctors, me. So I had the opportunity to talk about current MS treatment options, okay? And I'm just going to do a couple of slides, just basic multiple sclerosis, just as an introduction. I know this is a review for most of you, but remember, the thing that we're talking about here, the disease we're trying to fight, is multiple sclerosis. And this is an immune system disease where the immune system is attacking our own brain and spinal cord and causing all kinds of neurological symptoms. The hallmark of MS, multiple sclerosis, is multiple different symptoms or attacks over time. It can really affect anything: vision, strength, sensation, cognition, mood, bladder function, sexual function, etc. So as you also may know, MS does happen to affect women more than men, but we have a lot of men with MS, of course, but the ratio is about 2 or 3 women to each man. And it often is diagnosed or strikes early on, age 20 to 40. We don't have a cure yet, so patients can have MS for a long time. Because MS affects us when we're young, it can have this sort of disproportionate effect. And stroke, Parkinson's disease, cancer, these are bad things, but they often strike later in life. MS affects people really at their prime when they're just starting to have a family or just starting a career, so it really has great impact. We see it mostly in Northern America and Europe. So if you looked at a map, MS is not actually everywhere on the planet equally as far as we can tell. We're kind of at ground zero of that. We have a lot of MS in the US. We were just talking, Lex and I, that 1 in 1,000 Americans has MS. That's 400,000 Americans with MS, and about maybe roughly 2 million people throughout the world with multiple sclerosis. Some people ask, is it genetic? We're not sure. I don't think we think it's purely genetic. As I said, 1 in 1,000 Americans with MS. If you have a parent or a sibling with MS, your risk is a little higher. It's still, just a couple percent. I think if you're thinking of having children, I don't usually recommend factoring in MS or not, but statistically, we see a slight increase. If you have twins, if you had 2 identical twins and one has MS, I would actually bet money against the other twin having MS, but 1 in 3 identical twins could have that kind of matching. So there are different types of MS. The typical type are attacks of MS, relapses, exacerbations, whatever term you use for that. Patients will, in time, have different episodes of multiple sclerosis. That's a kind of MS that we mostly focus on treating, but some people with MS, after time, start to gradually get worse with time. We call that progressive MS. I'll be honest and say, at this moment, we don't have great treatments for that phase of MS, but we're definitely working on that and hope to have some options soon. So my talk is going to be about how do we treat multiple sclerosis currently. And it kind of reminds me, I was just thinking, my MS career started in maybe 1978 or 9 when I was in elementary school, and we had something called an MS readathon. And I did not know what MS was, but if I read a book, my mom would give me a quarter, and I would put it in a box, and I would turn it in at school, and it was really exciting. So that was my initial experience with raising funds for MS research. But actually, I'll be honest and say we didn't really have good treatments for MS for a long time. People have known about multiple sclerosis historically for centuries, but there was literally nothing that could be done for multiple sclerosis. We just had sort of an interesting time this month, so I was going to sort of frame it with presidential elections. So when Bill Clinton was elected president in 1990, there were no treatments for MS. So I think we kind of forget how recently it's been that we did not have tools to treat multiple sclerosis. So in 1992, there were exactly 0 FDA-approved treatments for multiple sclerosis. Now, when he was reelected, in the early to mid-90s, we did have some options. Some of you may be familiar with interferon treatment. The first brand that was approved is beta-seron. Some of you may remember there wasn't enough to go around. There was literally a lottery. You would have to get a number. If your number was low enough, you could get treated, but if not, you had to wait until they were able to ramp up production. There are different forms of interferon, and so we did have a couple of tools available in 1996. Now, if we jump to 2000, we had a couple more tools. Some of you may remember this era. If you went to talks, we would use the brand letters, and we talked about the ABCs of therapy. We had 3 different injectable brands of medication with the initials A, B, and C. There was another chemotherapy agent that was used a little bit. I kind of italicized it because it's not something that we use as commonly anymore. But we did have, again, we had some tools, and some of you may remember this era. You come in, and we had these 3 different options. We sort of debated which was more effective. by second term. But you notice the president's also aged quite a bit, like from photo to photo. It's, they get kind of older. But so we had a number of different treatments. We had more injectable therapies. At this point, at least 4 different brands of injectable therapies, and a new medication came out, an IV treatment, Tysabri, natalizumab, a once-a-month infusion. I put it in italics because a little bit after it was introduced, it was actually pulled back due to some safety concerns, so there was sort of in suspended animation. But by 2008, the medication had been brought back. So Tysabri had been brought back, and some of you may be familiar with this, with a little bit extra special monitoring, we're able to use this medication. So that brings us to 2008. We have a number of different injectable therapies, including some intravenous therapies that we were using to treat multiple sclerosis. Now, while Barack Obama was president, we sort of moved into another era. So by 2012, he looks much more serious in this picture, but we see that there are a number of other agents, including sort of the transition into pills for MS. So at this point, we had a couple of different pill options to treat multiple sclerosis. So remember, again, from my youth, even from when I was in medical school, I had an MS lecture in school, and it just talked about the disease, and the lecture ended because there were no treatment options when I was in medical school. So we went from no treatment options at all to actually a decent number in 2012. Well, a lot's changed in the past 4 years even, all right? So I don't want to shock anybody. But it's been kind of a shocking year, not necessarily because of the election results, but because of the explosion in MS treatments. I can barely fit them on the page. We have so many more treatment options now for multiple sclerosis, including more pills and more advanced therapies. Now, I have to be honest, when a patient comes to see me in clinic, I really can't go through all 14 different FDA-approved drugs. Later this year, we anticipate a 15th FDA. I can't really go through them all one by one. So I usually kind of break them down into categories. So when I'm talking about MS medicines, I sort of start out talking about our first generation of medications, our injectable therapies. And there's 7 different brands. Sometimes I use my hands because I remember there are 5 different forms currently of interferons. Okay? Interferons are, our bodies make interferon, but we can use interferon to help control the immune system a little bit. You know, if I get very nerdy, you know, I can go kind of like, you know, a Spock-like, you know, because we have 2 forms of beta interferon 1b, 2 forms of beta interferon 1a, and a kind of a, we call pegylated, but sort of an extended release form of beta interferon 1a. So 5 different forms of interferons. If you look at the brand names, many people in this room may have been on some or several of these medications. They share certain properties. They're definitely good at reducing MS attacks and inflammation. They can have some flu-like side effects, usually manageable. On the other hand, we have 2 other injectable therapies, glatiramer, 2 different brands now, Copaxone and Glatopa, a generic form of it, different from interferon. Still injectable therapies, also effective. Maybe not so much flu-like side effects. Some people have injection site reactions or other complications. But these were our first generation medications, and believe me, I prescribed a lot of these medications over the years. They are effective and still in use today. We do, however, as I mentioned, since 2010, have 3 different pill options for MS. So there are treatments that can control MS that don't involve injection. There are 3 different brands. Each one's quite different. You know, maybe it'd be a fun talk to go through each of the different agents. You may be familiar with Gilenya, Aubagio, or Tecfidera. It's either once or twice a day. Each one is slightly different in terms of its side effect profile. I'm going to just throw out my opinion that I think they're at least as effective, if not maybe a little more effective than our first generation of injectable therapies. I do think that they're well tolerated. Some people would say we do have to be aware of safety issues and be careful in terms of close monitoring with these medications. And then our third category, I kind of struggled with a name for this, but I think of we call them monoclonal antibodies. These are synthesized products that are administered that sort of help control the immune system using other forms of antibodies. I mentioned one of the early ones, Tysabri, which is still in use, a once-a-month infusion. More recently, we had the approval of something called Lemtrada, which is IV medication that's given, sort of has a unique administration of 5 days in a row, and then that's your treatment for the year, and usually a 3-day booster a year later, and that's sort of how that medication is used. Very recently, we had a medication approved called Zimbrita, which, you know, I have 2 IV bags and a needle, because Zimbrita is a monthly self-injection, a small needle that you give to yourself once a month. I put these together because one thing these medications share is the need for very careful monitoring. We're now using this term REMS program, where we do extra monitoring. And that can take the form of extra blood work, close follow-up with physicians. In Zimbrita's case, technically we should have a back and forth where you're touching base with your physician on the lab results to make sure that you're able to take that medication. So I don't necessarily have a lot of time maybe to go through each drug in detail, but I just wanted to give you that overview that we have a lot of tools for MS, but at least in my mind, they do fall into that category. Our first generation of injectable therapies, we have 2 decades of experience with those medications. We know that they're effective. We know that they have a side effect profile, but it's relatively mild. We do have pills for MS as an option, which you could discuss with a physician if that makes sense for you. Some people would say we have to monitor a little bit more closely with those medications, but again, the convenience of oral medications. And then we do have these monoclonal antibodies. Some people might say kind of like our bigger guns, but they definitely require much closer monitoring. Our FDA has suggested with at least some of these medications that you should have tried other medications before your physician should prescribe them. So all of the medications do a few good things. We know that they reduce those MS attacks. So when we're talking about relapsing MS, attacks of MS, we want to reduce the number of those attacks. These medications also help to prevent those MRI lesions. When you see your doctor or you get an MRI and we're looking at those spots, we don't want to see new spots on that MRI and follow-up. We don't want to see active lesions, enhancement after they give you the gadolinium injection. So these medications help us to do that. And I think I would argue perhaps most importantly, the medications are there to slow down or prevent disability progression. We don't want to see more disability accumulate over time, more trouble walking, more pain, more symptoms, more cognitive issues. I will say, and again, this is sort of editorial, that I think early effective treatment is important. There was a time when medications were new where people were maybe slower. They said, well, they might have said, I don't know about how that sounds. I'm a little worried about it. Let's see how I do. If I have some problems, I'll come back. And I have to say, we really think that we do lose ground if we use that strategy. These medications are preventative. The earlier we can prevent things, the better you're going to do in the long run. Waiting until problems show up and then trying to treat, we'll still do it, it's just harder. So earlier treatment is better. The last thing I would point out is that treatment does need to be customized. So at Georgetown, you've seen we have a lot of different providers. As you see, we have a lot of different MS treatment options. It isn't really one size fits all. Sometimes patients will ask me, okay, fine, you went through this, actually, which one is the best? And I can't answer that. There is no one best medication. I would say at our center, we literally have patients on every single one of the different products that I just mentioned because every patient is an individual. This will be a conversation about that you'll have with your provider in terms of which of these options makes the most sense for you. So that's really my introduction. I do want to give another thank you, which really is, as Dr. T, it's really to this audience, because in order to get the options that you see on the screen require thousands of people participating in different clinical trials. You heard that with Lexi, kind of directing our clinical trial center, we have, what did we say, 20 different clinical trials. This has been going on for the past years, and the direct result is these options that we have available. So really, I wanted to just say thank you to those of you in the audience who might have participated in a clinical trial or are thinking about doing so into the future. So again, thank you.